Let me introduce our next speaker, Dr. Kathleen Loomes, who is a professor of pediatrics at the University of Pennsylvania and one of the lead hepatologists at the Children's Hospital of Philadelphia. Dr. Loomes has been studying Alagille syndrome and other cholestatic disorders, both from the mouse perspective and from the gene perspective, as well as from the human perspective. So really delighted that she's going to give our next talk, which is entitled Potential Therapeutic Roles for IBAT Inhibitors in Cholestatic Liver Disease, the case of Alagille syndrome.
Thank you, Dr. Carpens. Thank you so much for the invitation and to the organizers for inviting me to speak on this topic today. My disclosures are listed here. The objectives for this presentation are to describe the pathophysiologic features of cholestatic liver disorders, as well as the clinical outcomes, and describe the current therapeutic approaches that we have to these liver disorders, as well as where IBAT inhibitors may fit into this paradigm. As pediatric hepatologists, we often see children presenting with cholestatic liver disease, and these have in common a pathophysiology of retention of bile acids that results in liver damage over time. The most common pediatric cholestatic liver disease that many of us see is biliary atresia, which is a cholangiopathy that presents in the neonatal period and results in complete obliteration of the extrahepatic biliary tree. This devastating disorder is the most common indication for liver transplant in children, with up to 50% of infants requiring transplant by 2 years of age. Even if bile flow is reestablished by a successful Kasai portoenterostomy, most of these patients will develop biliary cirrhosis and associated complications, and many of the patients will still require liver transplantation during their childhood. In new work performed by the Childhood Liver Disease Research Network and presented today at this meeting by Sunny Harpavat, we have learned that infants who have a successful Kasai hepatoportoenterostomy, who have lower serum bile acid levels at 6 months of age, have improved long-term outcomes. And this suggests a relationship between retention of bile acids and outcome in biliary atresia. Another category of pediatric cholestatic liver disease that we often see in pediatric hepatology is PFIC, or progressive familial intrahepatic cholestasis. These are inherited disorders that are all related to genes that are important for bile flow. These diseases have a wide spectrum of disease phenotype from mild to severe, and this is often related to the mutation type. The schematic diagram on the right side of the slide shows several of the genes that are important for different types of PFIC. For example, FIC1 is a phospholipid flipase that's important for maintaining the phospholipid composition of the canalicular membrane, while BSEP encodes the bile salt export pump, the primary transporter of bile acids into bile, and MDR3 is responsible for phospholipid transport. These, as well as other genes, including TJP2, the FXR bile acid nuclear receptor, and the protein trafficking gene MYO5B, are important causes of pediatric cholestatic liver disease, and they all result in the final common pathway of impairment in bile flow and retention of bile acids. Alagille syndrome, which we'll discuss in a bit more detail, is characterized by intrahepatic bile duct paucity, cholestasis, and multisystem involvement. In contrast to the other disorders, this is a developmental defect resulting from impairment in Notch pathway signaling. Many of the patients with Alagille syndrome will have mutations identified in JAGID1, which encodes a ligand in the Notch signaling pathway. In the diagram on the right side of the slide, a whole mount ink injection of the biliary tree in a mouse liver shows decreased bile duct branching in the JAG1 mutant animal as compared to the wild type on the left. These three categories of PFIC, Alagille syndrome, and biliary atresia are some of the most common pediatric cholestatic liver disorders, and they all have in common a pathophysiology that involves hepatic accumulation of bile acids playing a role in liver injury and damage. We have a clear unmet need for new pharmacologic treatments for these conditions, and the IBAT inhibitors are candidate molecules that may fill this need. Now, a little more detail about Alagille syndrome and a case presentation that will help to frame the rest of our discussion. Alagille syndrome is an autosomal dominant disorder that is characterized by bile duct paucity and cholestasis, as well as cardiac defects, characteristic facial features, vertebral anomalies such as the butterfly vertebra seen here, and eye findings such as posterior embryotoxin. A subset of the patients will also have renal and vascular involvement. Up to 94% of patients who meet clinical criteria for Alagille syndrome will have mutations detected in JAG1, encoding a Notch pathway ligand, and about 2 to 4% will have mutations detected in the Notch2 gene. And now a case. This is an 8-year-old presenting with Alagille syndrome, cholestasis, and worsening pruritus. She was diagnosed during infancy when she presented with cholestasis at about 4 months of age. She had a liver biopsy done at that time, which did not show bile duct paucity, but this is not unusual in children who have biopsies done before 6 months of age. She did, however, have characteristic facial features and peripheral pulmonic stenosis. She had no vertebral or eye anomalies detected. Her genetic testing revealed a heterozygous nonsense mutation in JAG1. A recent publication by Gilbert et al. Categorized all reported mutations in Alagille syndrome, and you can see from this pie graph that more than half of them are truncating mutations such as frameshift or nonsense mutations, as this patient had. When she presented to clinic, she complained of worsening pruritus that was impairing her sleep and concentration at school. She was scratching frequently and causing bleeding on her skin. Despite these complaints, she had a good appetite and energy level. She was currently being treated with an antihistamine, as well as ursodeoxycholic acid, rifampin, and fat-soluble vitamin supplements. Her physical examination was remarkable for normal growth parameters, jaundice, hepatomegaly, and skin excoriations. Laboratory testing revealed hyperbilirubinemia, elevated liver enzymes, elevated serum bile acids, and cholesterol. Of note, her platelet count and INR were both normal. So, in light of this clinical presentation, what would be your next step in treatment for this patient? Would you add naltrexone, add sertraline, refer to surgery for biliary diversion, evaluate for a liver transplant, or enroll in a clinical trial or expanded access program for an IBAT inhibitor, if available? Please vote now. We have the results here. So almost 3/4 of the participants picked the last option, which is to enroll in a randomized clinical trial or expanded access program for an IBAT inhibitor, which is in keeping with the topic of our symposium. And then a smaller percentage recommended adding naltrexone. There we are. So as we consider the various treatment options for this patient, we should think a little more about the natural history of liver disease and Alagille syndrome. The liver disease manifestations in Alagille syndrome are highly variable and can range from mild to quite severe. The liver disease does not correlate with the type of mutation in JAG1, so there is no genotype-phenotype correlation in this disease. A subset of patients may have very mild manifestations, including isolated biochemical abnormalities that usually include a high GGT. The majority of patients may have some element of cholestasis, which can range from mild to profound and manifest by pruritus, xanthomas, as seen here with this patient who has very extensive xanthomas over the backs of her legs, and fat-soluble vitamin deficiencies. In many patients, the cholestasis may improve over time, but some patients may have progression to portal hypertension and even cirrhosis, and liver transplantation may be required in over 50% by adulthood. We can learn a little more about the natural history of cholestasis and Alagille syndrome from a recent publication from the Children Network. This paper by Kamath et al. Was recently published in Hepatology Communications and reports the outcomes of childhood cholestasis and Alagille syndrome. These are the results of a multi-center observational study and enrolled 293 participants with Alagille syndrome who had cholestasis and their native livers. In the graph on the upper part of the right hand of the slide, this is a graph of the total bilirubin trends over time in this patient cohort. This is a logarithmic scale, but it does show a decrease in bilirubin over time, which is associated with also an improvement in cholestasis in this patient cohort. In the graph on the lower half of the slide here, the platelet count also decreased over time, which suggests that there is development of portal hypertension in these patients. In addition, the investigators found a decreased burden of pruritus and xanthomas over time in this patient cohort. But as shown in the survival curve on the right side, the estimated transplant-free survival was only 24% at 18.5 years of age. In those patients who survived to 20 years of age with their native livers, 40% had definite portal hypertension, as defined by splenomegaly and a platelet count less than 150,000, or development of complications. This study shows that there was a previously unrecognized but significant burden of progressive liver disease in Alagille syndrome. We currently have a number of different medications as well as surgical interventions in our toolbox for treatment of cholestatic liver disease, but we still do have unmet needs, and we would like to have additional interventions that we could offer to our patients. The patient that we presented in this case was already being treated with antihistamines for itching, as well as the cholinergic ursodiol and the PXR agonist rifampin, but she was having persistent symptoms. Naltrexone as an opioid antagonist might be a good option as a next medical intervention for her, as would possibly sertraline, an SSRI that has been studied in pediatrics with some positive effects. In addition, bile acid binding resins are another option that can increase excretion of bile acids in the stool, but they are unpalatable and have many drug interactions that make them difficult to use. We have some surgical options in this patient population. As shown here in the schematic diagram from Casper Wong's 2017 hepatology paper, either a partial external biliary diversion or an internal biliary diversion has been shown to be effective for reducing pruritus in both Alagille syndrome and PFIC. In addition, the data from the NAPID consortium has shown that a subset of patients with PFIC who successfully have a significant decrease in serum bile acid levels after diversion can derive long-term benefit and survival with native liver. However, this is a rather invasive option for our patients to consider. Of course, liver transplantation remains a life-saving option for patients who are refractory to other therapies or who develop progressive liver disease. But there is still a major unmet need for medical interventions that could impact the natural history of disease in these cholestatic liver disorders. And IBAT inhibitors may fill that unmet need. So in conclusion, biliary atresia, PFIC, and Alagille syndrome represent three of the most important liver diseases that cause a significant disease burden to our patients and result in the need for a liver transplant. In these disorders, we lack effective therapies and strategies to help impact the natural history of disease, and IBAT inhibitors inhibit bile acid reuptake in the ileum and form a sort of medical diversion that may result in net loss of bile acids. These drugs have potential to improve debilitating symptoms while potentially impacting the natural history of disease. IBAT inhibitors, as we'll hear from Dr. Karpin, are currently under investigation in clinical trials and may be part of our therapeutic armamentarium in the future to help our patients avoid liver transplant and progressive complications of their disease. Thank you.